Of an infertile female. Okay. So, what defines infertility in a female? This we have been learning since our post graduation and all. Okay. But in 2023, there was a slight change in this definition, and it is defined as inability to conceive based on the medical, sexual, and reproductive conditions, age, and examination findings and diagnostic criteria, or a combination of any of these factors identified in one particular group. So this period of 12 months of regular unprotected intercourse has been taken out and it has been replaced by these criteria. Okay. So when to evaluate? So based on the age of the female partner, we suggest evaluation for the couple. So if the age of the female partner is less than 35 years, then we suggest 12-month period of unprotected intercourse as a guideline. But if it is more than or equal to 35 years and less than 40 years, then 6 months of unprotected intercourse will suffice for you to start the evaluation of the female partner. But if the female partner arrives to you at 40 years of age, do not waste any much time and start the fertility evaluation immediately. Okay? So apart from these, also in females with certain identified risk factors, like those with already irregular menstrual cycles and those with cycle length shorter, like less than 25 days, and those with intermenstrual bleeding or oligo and amenorrhea, and these cases we have to start immediate evaluation irrespective of the age of the female partner. So apart from these, already any known uterine or tubal or peritoneal disease, say suppose a female might have undergone laparoscopy for some other indication like appendicectomy or something which was done when she was 20 years old or something, and one tubal factor was identified at that case. In such cases also, based on the previous history, do not waste any much time and start evaluation immediately. And already when the couple identified a male factor subfertility or azoospermia, in also such cases, you have to start immediate evaluation for the couple. Also in the cases of sexual dysfunction and in cases where genetic conditions, identified genetic factors like any genetic condition running in the families or diminished ovarian reserve, also don't waste time and start evaluation immediately irrespective of the age of the female partner. And this is the case which I mentioned previously, like in those cases with recurrent pregnancy loss and also where either of the partners, like either the male partner or the female partner, has been identified with any genetic condition which was running in the family, or they might have been carriers of one particular type of mutation. In such cases also, we need to start fertility evaluation immediately without wasting much time. So what is the history that we need to consider in the female partner? So when coming to the female partner, length of the time of unprotected intercourse is important, because the couple might have been staying away, like maybe the wife or husband might be staying in a different country and all. In such cases also, based on the history, we need to plan our evaluation. And coital frequency, ideally at least every third day or every fifth day will be ideal for a couple with wherein a woman having regular menstrual cycles. The chances of conception might be better. And the use of ovulation monitoring, like whether they have been using any urinary LH kits, or some people monitor by basal body temperature and all, which is not so reliable. And if they are using any fertility tracking apps which are widely available these days, you need to just update the couple that reliability of apps may not be so up to the mark and all. Okay, and also you need to ask about any sexual dysfunctions like decreased libido, dyspareunia or vaginismus. Such factors might be very ignored, but we need to have a keen eye on them to identify those factors and suggest corrective treatment accordingly. And you need to have a detailed history of the prior fertility treatment and what was the outcome of that. So say suppose a couple walks into your clinic with a failed IVF cycle. So in such cases, you need to be very cautious of the history of the previous IVF cycle. Like what was the ovarian reserve at the time of starting IVF cycle, and what was the indication for which IVF was done. And are there any associated factors like endometriosis or PCOS which might affect the quality of the oocyte? And how many oocytes were retrieved? And how many embryos were formed finally? And what was the quality of the oocyte and the sperm and the embryo grading which was obtained? Whether it was a blastocyst or a day 3 embryo, and what's the quality of the embryo. So all these details we need to go into depth if the patient has any history of previous IVF cycle, so that will help us in planning future IVF cycle for her. Okay. So, and are there any prior periods of intercourse without contraception or with a low efficacy contraception like barrier contraceptives and all? So coming to the gynecological history, as you also know very much that menstrual history is very significant in those couples who are planning pregnancy. Okay, so the woman needs to have regular cycles for them to have a higher chances of natural pregnancy. So age at menarche, cycle length. If the length is too long, say suppose more than 35 days, or the woman is having less than 5 cycles in a year, all these are suggestive of oligomenorrhea or amenorrhea, which will shift our focus towards investigating that factor much. Like you can think about doing a thyroid profile for her, or in case there is a symptom associated with galactoria or visual field defects and all. In such cases, you can dive into getting fasting serum prolactin done. Okay, or if all these are ruled out, then you can dig more into PCOS and all. Those the cycle length itself gives us a critical idea about which angle you need to investigate more. On the contrary, if the cycle length is shorter, say if it is somewhere around 23-day or 25-day cycle, in such cases you need to look into diminished ovarian reserve. Like you need to get ovarian reserve testing done, like serum AMH or antral follicular count, and then see whether that is on the lower side or borderline AMH and all, and then guide the couple accordingly. So that's the significance of cycle length. And duration and amount of bleeding, which will be prolonged in case of oligo and amenorrhea with induced menses and all, and presence of any intermenstrual bleeding, which might be the case with cervicitis or any cervical fibroid or polyp and all, dysmenorrhea and molimina. Cycle length, as I have told previously, we need to dive more into ruling out hypothyroidism, PCOS, and hyperprolactinemia if the history suggests. Like hyperprolactinemia, fasting serum prolactin, you need to get it done when there is amenorrhea coupled with galactoria, like when there is the woman is having either serous or milk discharge from the breast or any visual symptoms associated with that. In such cases, we need to get fasting serum prolactin done. Otherwise, routine TSH and ruling out a PCO will be more than enough. And the general gynecological history pertaining to any cervical screening, like previous pap smear, was it done, and any abnormal cervical screening or related treatments like conization or any cryotherapy or electrocautery was given, or contraceptive use including the duration and type of the contraceptive, and history of pelvic inflammatory diseases and chronic pelvic pain needs to be ruled out. And this fertility evaluation should always be taken as an opportunity to have an initial pap screening. Like that is the opportunity you will get to screen the woman for any cervical abnormalities. So you should use it like a basic pap evaluation should be done at this stage, so that can be used for her to compare in future psychological studies and all. So coming to the obstetric history, which is the case with secondary infertility, you need to have an update of total number of pregnancies and what was the outcome of each pregnancy. whether it was a biochemical pregnancy or a clinical miscarriage or pregnancy of unknown location, and what was the mode of termination in case of miscarriages, like whether medical termination was used or any evacuation was done, and history of ectopic pregnancies, which will prompt us more into any past history of pelvic inflammatory diseases, and history of stillbirth, and whether it was a live healthy baby and all, and what was the method of conception, like whether that was a natural conception or conceived through fertility treatment or IUI or IVF. We need to make a note of what conception it was. And you need, in current days where there is increased rate of divorce and second marriages and all, you need to always have a history of whether the previous conception was with the current partner or a prior partner. This also is important. And whether there were any obstetric complications like severe postpartum hemorrhage, or whether there was any cervical manipulation done and all in the previous delivery. So all this will give us a hint of what could have been a factor in difficulty in having the present pregnancy. So apart from these, any congenital disease or birth defect in the offspring and genetic factors are to be implicated if there is any multiple pregnancies with the baby having a bad obstetric history, or birth of the baby suggestive of syndromic genetic defects and all. In such cases, they should be guided for genetic counseling and evaluation. Coming to family history, you need to make a note of any family members with the history of inherited diseases, autosomal recessive, or history of any genetic abnormality in the family. Okay, that will hint us towards need for genetic evaluation in the couple, and how to plan a better pregnancy for them, whether to make use of IVF with PGT to give them a better obstetric outcome and all. And any developmental delay which is suggestive of Fragile X, and infertility, whether there is any family history of infertility, that you need to rule out, and early menopause, which is suggestive of autoimmune or genetic cause, and you need to have a look on the endocrinopathies and history, family history of any birth defects and multiple abortions, and also heritable cancer syndromes pertaining to the family history. Coming to the social history, so smoking, alcoholism and recreational drugs, you need to have a note of them. If the couple is having any of these, we need to advise them to quit smoking and recreational drugs and limit the intake of alcohol, both for male and female partner. And occupational and potential exposure to toxic agents like endocrine disrupting chemicals, parabens, phthalates and bisphenols also needs to be inquired about, and advice regarding limiting the exposure of these agents. And dietary and exercise habits. These are particularly stressed upon because you will be the first contact for every couple who are planning pregnancy, and in each visit we should reinforce the importance of dietary and lifestyle changes. Okay, so in every visit you have to counsel them to maintain an optimal BMI and reinforce about regular exercise. Okay, and history of any psychological or sexual trauma which might have an impact on other factors, like it might affect the reproductive history of the couple. So these might look insignificant, but these need to be asked for the couple to plan a better pregnancy for them. And apart from this, male partner history, that will be covered by Dr. Harika in the coming class. And coming to physical examination, so the examination should be targeted to identify the specific factors associated with infertility. So these are the things roughly we look around in the general and local examination. Like for skin, in case of oligo or amenorrhea, we might have hirsutism, acne, acanthosis nigricans, or alopecia, androgen alopecia, which might be there in PCOS. Okay, and in extreme cases, then we need to rule out androgen secreting tumors or conjugal adrenal hyperplasia also. And in the neck, we might have to, when there is a goiter or an abnormal thyroid function test, you might identify a thyroid nodule. So you have to have an eye on that and check regarding the size, nodularity and rapidity of the growth if the patient is coming for follow-up and all, and cervical endopathy. And whenever there is a rapid growth, you need to refer to an oncologist for a proper treatment. And coming to the breast, there might be a nipple discharge, pain or mass. You need to look for fasting serum prolactin if there is any galactoria along with amenorrhea. Okay. And speculum examination, when there is dyspareunia or postcoital spotting and all, you need to look for local abnormalities like whether there is any vaginal infection or cervicitis and all, is there any cervical polyp, okay, that could have been a cause of these symptoms. Bimanual examination, it is not routinely indicated per se in a case of infertile female. As such, ultrasound TVS will give more information than a bimanual examination. So TVS is advised routinely in a couple who are planning pregnancy. Coming to the diagnostic evaluation, so how should it be conducted? It should be conducted in a systematic, expeditious and cost-effective manner to identify the relevant factors with emphasis on the least invasive methods for detection of the most common cause of infertility. So suppose the couple walks into your clinic with a marital life of 3 years, young couple. So for her, you might advise tubal evaluation. So what will be the first test that you will advise for tubal evaluation? Which is? So the most cost-effective investigation is HSG for identifying any tubal factor. So rather than going for laparoscopy, which is expensive and which is invasive procedure, we will opt for HSG. So, and the pace and extent of evaluation should take into account the couple's age, their fertility preferences and duration of infertility, and features from the history and physical examination. So the thing is, if there is any couple coming to you from the US or Australia or somewhere, they have a time limit. So the infertility evaluation for them should proceed in that pace which corresponds to them. You can't just tell them, okay, you go for time intercourse for 6 months and see me later. So first you need to evaluate them as rapidly as possible, like what all you can plan for them, and then get it done, and based on the treatment you can advise them. Okay. Ovulatory function. So test to identify ovulatory function. It is seen in ovulatory dysfunction is seen in 15% of infertile couples and in 40% of infertile women. Oligo or amenorrhea is clinically sufficient to establish diagnosis of anovulation. No further evaluation is needed in those cases coming to you clearly with a history of oligo or amenorrhea. They will have ovulatory dysfunction in any case. So in those, for us the critical thing will be those who are having regular menstrual cycles. So for those who are having regular menstrual cycles, if it is a non-hirsute woman, the chances of cycle being ovulatory are 99.5%. Okay. So in a woman, non-hirsute woman with regular menstrual cycles, the chances of her cycle being ovulatory is 99.5. You did not get any evaluation, any ovulatory kit done in that. Okay. But there might be sporadic anovulation of 1 to 15% in these cases. But those women with regular menstrual cycle along with hirsutism, in them the chances of cycle being ovulatory are 60%. So in these women you might have to take the help of other supportive measures to identify ovulation. Say suppose you can get a luteal phase progesterone done 7 days before the expected menses. If it is more than 3 nanogram per ml, then it is a presumptive evidence of ovulation in them. And ovulation predictor kits, as you know, these are not so reliable, and incidence of false positive and false negative are very high in these cases. And transvaginal ultrasonography, as I said, it's the gold standard investigation to evaluate an infertile female. It will help us to know the baseline ultrasonography of a woman. In the ovaries, we will see the ovarian reserve. We can rule out PCO. And any other adnexal lesions are there, we can identify that. In uterus, you need to look about how the uterus morphologically is. By the means of 3D ultrasonography, you will be able to make out, in fact, uterine abnormalities with relatively good accuracy, as much as an MRI. So 3D ultrasonography is very important. And for a woman coming with infertility to you, this will give a lot more information than any other investigation. So in the uterus, you need to look for any morphological abnormality of the uterus or any lesions like fibroid or adenomaloma or adenomyosis, diffuse adenomyosis of the uterus. In fact, endometrial polyps also can be delineated with very much accuracy with 3D ultrasonography. Okay. So apart from that, you can identify evidence of ovulation with ultrasonography, transvaginal ultrasonography. Basal body temperature, this is very unreliable and tedious for the couple. Endometrial biopsy as a mode for identifying the ovulation is no longer being recommended these days. There were days when we used to do laparoscopy to routinely check tubal patency. Along with that, we used to scrape the endometrium to send for histopathology to identify ovulation. But the days are gone, and transvaginal ultrasonography has replaced them. Coming to hormonal testing, so whenever, as I said, told previously, oligomenorrhea or amenorrhea cases, you need to have a look on TSH. And in amenorrhea cases, if the TSH is normal, then you need to step on to FSH and E2 to differentiate between WHO type 1 and type 3 anovulation. Okay, and coming to clinical signs of androgen excess, in such cases you might have to rule out congenital arterial hyperplasia. So 21 alpha hydroxylase deficiency has to be ruled out. Ovarian reserve, female age is the single most important predictor of fecundity, and ovarian reserve test should not be routinely recommended in every woman who is walking into fertility. In only those whom you suspect that there might be decreased ovarian reserve, say suppose in those with cycle length less than 25 days, or in a woman where there has been history of previous ovarian surgery, okay, or in women who has taken any gonadotoxic therapies at all. In such cases, you might have to do the ovarian reserve testing, or else in a woman with regular menstrual cycles, apart from any other thing, you need not get a routine AMH test done unless you suspect any decreased ovarian reserve. Incidentally, you have done a day 2 scan and you see lesser number of follicles, but the woman is having the regular menstrual cycles. In such cases, you can get an AMH test done to correlate it whether that is only for this cycle or is it really the ovarian reserve is low and low. Okay, so why do you need these ovarian reserve tests? We need the ovarian reserve test to counsel the couple about how the chances will be. Usually they are taken like how to counsel the couple regarding the prediction of having pregnancy in IVF. Okay, so the women who are having lesser ovarian reserve, they might need multiple cycles of IVF to have a live birth. On the contrary, the women with normal ovarian reserve and PCOS, they might, one cycle might suffice in them. So these ovarian reserve tests are used by us to counsel the couple like how the chances will be when they go for IVF or ART procedures. And the goal is to identify poor responders to gonadotropin stimulation. As I told, those who have lesser diminished ovarian reserve they might have poor response. Okay, so, and also to give a realistic expectation to the couple on how the chances of pregnancy will be with one cycle of IVF. So, poor ovarian reserve that does not necessarily imply inability to conceive or support. Not all the women with diminished ovarian reserve might need IVF to get a successful pregnancy. So, it's not that when there is decreased ovarian reserve, we should definitely counsel the women for IVF, but we should alert them on what the chances will be, and if the couple is ready to take a decision that whatever happens, we want to try naturally, we are ready to go ahead with donor gametes if the reserve goes down critically. In such couples, you have to keep them informed, and it's our responsibility to tell them like not to waste much time and plan pregnancy accordingly. So, and it doesn't have any proven benefits in fertile women, as I told you. And these are the ovarian reserve tests, but AMH and antral follicular count are routinely done. Coming to the cervical factors, when there is any history of abnormal cervical discharge or previous cervical surgical procedures, then that has to be made a note of. And speculum examination of the cervix to look for cervical stenosis or any chronic cervicitis needs to be done. Post-coital test, there is no role of any post-coital test these days. Uterine abnormalities, as I told you, 2D ultrasonography transvaginal or 3D will be better, will give us a better estimate of like what the uterine anatomy is, whether there is any septum or it's a bicornuate uterus or a didelphys. We'll get a better picture on 3D ultrasonography, which is almost of similar sensitivity to MRI. And if there is any suspicion or abnormality noted, as I told, you need to go for 3D ultrasonography or MRI. Coming to the test for tubal patency, hysterosalpingography. This also evaluates the endometrial cavity, as I told, and it can reveal developmental abnormalities as well as endometrial polyps and intrauterine adhesions and submucous myomas and all. The drawback is that it has very low sensitivity of 50% and positive predictive value of 30% for the diagnosis of polyps and myomas in asymptomatic women. And it cannot reliably differentiate between septate and a bicornuate uterus because we can't make out the external contour clearly on HST. And sonohysterography, which is nothing but saline infusion sonography. We routinely do saline infusion sonography for tubal patency here at Fertility. So with using this under TBS guidance, using a small catheter, we pass saline into the uterine cavity and we look for the exit of the saline from the femoral end on both sides. It has a high positive predictive value than HSD and a negative predictive value of more than 90%. Hysteroscopy, it is done for uterine pathologies, like whenever you identify endometrial polyp or intrauterine adhesions or submucous myoma on 3D ultrasonography, then we post her for hysteroscopy for confirmation and also simultaneously treating it in the same setting. Hysteroscopy for it's the definitive mode of treatment for intrauterine pathologies, as I told you, but it's that it is expensive and requires anesthesia except office hysteroscopy. Tubal patency, as I told, HSD, sonohysterography, which we routinely do, and any case of proximal tubal occlusion or HSD, it needs to be further evaluated. It can be done by FTC, fallopian tube cannulation and all. This is about HSD. For tubal factors, it has a sensitivity of 76 to 96% and specificity of around 70 to 100%. And as I told you, laparoscopy per se is not routinely recommended for tubal evaluation. Only when it is being done for other indications, you can couple along with that. But the advantage is that simultaneously you can tackle any peritubal adhesions that are seen. This is what I told, like whenever there is proximal tubal occlusion, then you need to go for hysteroscopic selective tubal cannulation. Coming to the peritoneal factors, which are nothing but endometriosis and adhesions. So in a case of unexplained infertility, we need to have a look on this. And whenever you do a transvaginal ultrasonography, you will know whether there is an endometrioma or not. That will guide you towards the peritoneal factors. And laparoscopy is the only method by which you can identify the peritoneal factors. But the thing is that sadly, minimal and mild endometriosis doesn't have much impact on infertility, and those which, when it progresses to severe stage, it will be having symptoms like, as I told, chronic PID or something. You might have recurrent episodes of previous pelvic infections or pelvic pain or a pelvic surgery, and in moderate or severe endometriosis, you will be able to make that out on ultrasound at all, or an abdominal HSC. So these will have manifestations. The severe ones, which will have an impact on the fertility, will have other manifestations. So we need not do laparoscopy to identify peritoneal factor in such cases. And the milder ones, on the contrary, they don't have much impact on the fertility. So you need not do laparoscopy specifically to identify these peritoneal factors. So this female fertility declines with increasing age, and age is the single most important predictor of fecundity, that you already know. And a comprehensive medical, reproductive and family history combined with physical examination can reveal anatomical or physiological causes of infertility. So coming to conclusion, infertility evaluation should be initiated immediately if there is known medical history or any other factor identified that is associated with infertility. And evaluation and indicated treatment should be initiated based on the age of the female partner, which I already stressed on. And evaluation should include evaluation of ovulatory status, structure and patency of the female reproductive tract in the female partner, and semen evaluation in the male partner. And parallel evaluation of the male partner is equally important. And you can go for HSG or sonohysterography as initial test for tubal patency. And in those with regular menstrual cycles, as I told, 21 to 35 days cycle, additional tests to confirm ovulation are not needed. Ovarian reserve testing should not be used as screening test for women who do not meet the criteria of infertility, but it should serve as an adjunct for the evaluation of infertile women so that you can counsel them better on the chances of pregnancy. Fertility evaluation is also warranted in the case of recurrent pregnancy loss and genetic conditions where PGT is warranted. Laparoscopy, advanced sperm function testing like DFI and all, postcoital testing, chromophilia testing, immunological testing, karyotype, endometrial biopsy and serum prolactin, these are not routinely done as a basic infertile evaluation for women. Okay. So this is about evaluation of the female partner. So once we have evaluated and we have started the couple on, say it's a relatively younger couple, you have put them on ovulation induction with timed intercourse. So what will be the chances of natural pregnancy for one cycle for the couple? Young couple with no identified factors, with a marital life of 2 years. So what could be the percentage of pregnancy in one cycle? 60%. So always the couple come to us like when they enter the clinic, we put them on medication. Again the woman gets a cycle, she comes to us, why did it? You might be facing this frequently. Okay? So the chances of natural pregnancy for a relatively younger couple with no identified factors for one cycle of timed intercourse are 20 to 35%. That is the maximum. Counsel the couple like that. Okay? Because as per studies also, it is proven that for one cycle of timed intercourse, however well you time it, the chances will be 20 to 35%. So that will set the expectations of the couple to what the reality is. So that every month when they come back, they will also know that what the chances are. The doctor has already counseled me. So they will come back with that view and you can carry forward your treatment in a better way.
Does the fertility chance increase as the consecutive cycles go up?
Yeah, it consecutive cycles go up. All these are for couples with no other identifiable factors for infertility and relatively younger couple wherein the age of the female partner is less than 30 years. So the chances will go up with subsequent cycles. Say after 3 cycles it might be 57% and after 6 cycles it might go up to 72% and after 1 year it might go up to 85%. That is what we see, right? In the definition of infertility, at the end of 1 year, 85% of the couples conceive, while 15% might need fertility evaluation. That was the previous definition. So as the cycles go further, the chances of conception increases. But every month we'll be facing the patient. In fact, we will also be coming across patients like, we want natural pregnancy, so why did it happen? So we just are timing the intercourse, we just are making sure that follicle is growing, we are giving it trigger, the follicle is getting ruptured, the oocyte is coming down. Whether the mature oocyte is being caught by the fallopian tube, we are not sure. And whether it's getting fertilized by the sperm, we are not sure. Whether an embryo is formed or the embryo has come and implanted in the uterus, we are not sure of all these steps, even in IUI. So we need to counsel the couples accordingly about how realistic the picture is for each cycle of ovulation induction with time intercourse, so that you will not have to take too much of a process. Yeah.
So how long can we wait is because in a couple you are not identified with any of the factors, male or female. So how long
In such cases, you might try maybe 6 to 8 cycles is what I say, but not beyond that.
third or fourth cycle we go back and we see what we have
Everything,
missed.
yeah.
Or is it not happening? So at the max by fourth or fifth cycle
Yeah.
maybe we have to
I
check
would
them.
say rather than waiting for 1 cycles, it all depends on the couple's fertility preferences ultimately. So 6 cycles is what we can try as a baseline if no other factors are identified. But beyond that, maybe as you said, we need to go back and look into, like we might be missing some cases of minimal or mild endometriosis, which might be one of the factors in unexplained infertility. So we just have to suggest the treatment accordingly based on the age of the couple, their fertility preferences, their duration of marriage, and taking into factor all these considerations, it will give us a better picture to plan their fertility.
So you see like many of patients who come to them from the fourth cycle itself, maybe or maybe sixth cycle that you might need an extra step.
Yeah,
When you go back and the history doesn't
suggest it.
suggest anything. So for any advanced step by the time they reach fourth to sixth
Yeah,
cycle.
after 6 cycles of trying naturally, like we give the option to the couple. Like you can go ahead with advancing further your treatment with cycle of IUI, which might have benefit in cases of mild or minimal endometriosis or unexplained infertility, either way. So it depends on the couple's preferences actually. So if they are willing to go ahead with IUI, we need to explain them per cycle what might be their chances of pregnancy and then take it forward. Okay. So any more doubts in evaluation of infertile female?
Ma'am, is it necessary to do HSD before starting treatment? Like OI?
Some people say that we need to do HSG even before starting ovulation induction, but studies say that in those with no other history suggestive of tubal factor, like peritone, any history of recurrent pelvic infections or pelvic surgeries and all, we might start ovulation induction, but see if it doesn't work well in 2 to 3 cycles, better to get a tubal evaluation done, because they might not be convinced to do a tubal test at the initial visit itself. Yeah. So you can, in such cases with no factors suggestive of tubal factor, you can try for 2 to 3 cycles and take a decision accordingly. Any more doubts?
If a patient had a ectopic and wherein the tube was removed and it was sent for sister evaluation, and it reported it is reported as confirmed ectopic. Apart from that, if they see that there is any inflammatory picture, chronic inflammation in the tube, so definitely it will be there in the other tube. If it's an inflammatory disease. So how do you counsel them? You cannot go directly into jump into IVF, but give them option of IVF in such cases, or
It depends on how receptive the couples are. Okay, so we can't convince them after just one ectopic that the chances of natural pregnancy won't be there. Okay. So as you routinely do, after identify that ectopic and after surgery also you will put them on a course of PIDs, active PID for them. Okay. And then in the coming cycle, you can counsel them that chances of ectopic will be higher, which you usually do that. Okay. So based on the receptivity, if you can counsel the couple regarding going to IVF based on the semen analysis parameters and all, or age of the female partner, if they are receptive, you can push them towards IVF. But in such cases, even natural pregnancies also can happen with healthy liability. So you need to weigh and balance about the fertility preferences of the couple and their receptivity to go ahead. But you have to keep them informed that chances will be higher